Wonderful. Yeah. And let me just pull up the
Good afternoon, ladies and gentlemen. We will be starting very shortly. Just give us a moment to allow everybody who is in our waiting room to join us. And I can see the numbers are climbing as we speak. We have a hand up. Who do we have a hand up from? Nothing that I can see. All right, I want to thank everybody for joining us. Perhaps, Lynn, you could start the presentation with our introductory slides, and we'll get started with Patrick and others. Ladies and gentlemen, I want to thank you for joining today's webinar. We've had a little bit of a technical difficulty here with me. Thankfully, in the privacy of just the webinar with Patrick, shaking my fist at the blackening sky a few times. But I think we've got things worked out now. We have a very exciting presentation for everyone today. I want to provide folks a little bit of a welcome first to Patrick Murta, who's the Chief Interoperability Architect for Humana. Secondly, I would like to provide a little bit of overview of how we go about doing our webinars so that folks can participate and see what we're doing here. We are using social media to keep live tweeting and updates of today's discussion. If you are tweeting, we provide you some hashtags as well as our Twitter handles. Rules of the road, you'll be muted during the presentation. Please enter your questions into the Q&A box. We will take those questions and we will answer them with Patrick. Chat is disabled so that we can try to keep this as uncomplicated as possible. We're recording today's webinar and the video will be available to MHDC members within 3 days. And lastly, please take a moment to respond to the poll that we will be sharing with you just before the end of today's presentation. So let's go to the next page. For those of you who are unfamiliar with MHDC, we hope that's a shrinking number, but we know that we're small and we know that while we have large aspirations and great hopes, we don't wish to overstate who we are and what we do. We are an independent and unbiased convener of the health data community within Massachusetts regionally and increasingly nationally. We bring health data expertise in standards, regulatory changes, policy, et cetera. As I mentioned, we really have a local focus as a Massachusetts not-for-profit, but we are having an increasingly growing national presence. And we pride ourselves on invention, innovation, and incubation, taking the ideas often of others, for example, the Da Vinci Project, and moving that from the implementation guide to implementation and the steps that precede implementation, testing, understanding, the applicability to different trading partners and the like. So we practice what we preach, and we try to do it in a way that knits together some of the pieces that are missing in health data and will help organizations achieve the level of interoperability envisioned in the final rules with as much help as a community can bring to them. Why don't we go to the last page, Lynn? What do? We offer 3 services. We offer data governance services. What data need to be collected? In what vocabulary do they need to be represented? How do they conform to US CDI, US core, fire standards, et cetera? and what are the technologies or services that we need to think about to help payers, providers, and consumers make the most out of the opportunity to access and use health data. We also offer exchange services. We merged with the New England Health Exchange Network, a partner organization to ours for a number of years, earlier this year. And with the merger with NEHAN, we bring community exchange services, among the best EDI exchange, as well as a test bed for fire and an increasing array of fire interoperability use cases. Lastly, we provide analytics services. Our Spotlight platform combines clinical and business analytics, and we recently signed a participation to include the Lown Institute data on equity, overuse of care, and patient outcomes into our Spotlight analytics service. What we offer to the community are a range of things. Some are priorities for our members. Some are open to the community at large. They include the Vantage Point series, the interview series that we do with leaders in healthcare, the CIO or the Executive Forum, which we will be hosting our last session of the year next week with Anish Chopra, as well as leaders from Blue Cross Blue Shield of Massachusetts and the Brigham and Women's Hospital in Boston. And then webinars, of which this webinar is a part and which we're especially pleased to have. So with that, I want to turn the presentation over to your presentation, Patrick. And I want to thank you, give you an opportunity to introduce yourself, and then we can start going through today's discussion.
Great, Denny. Thank you for that warm welcome. I appreciate the opportunity to come present to the consortium today. I'm actually looking quite forward to it. I like to talk about interoperability and fire and integrated care delivery. So this is a really, really good session. I think we've got some good educational material that will hopefully facilitate a really good session here and also a lively Q&A. So, as we're bringing up the slides here, just a little bit about myself. As Denny noted, I'm Patrick. I am Humana's Chief Interoperability Architect and Architect Fellow. I've been with the company for 25 years at this point. In that time, I've spent about 25 years in health IT, going from some of the models that Denny was talking about just a second ago, cutting my teeth back in the world of X12, late 90s, early 2000s, through HL7B2, CCD transactions, and over the last 5 to 6 years, focusing, actually it's been longer than that at this point, on contemporary models such as FHIR, CDS hooks, other types of contemporary integration or interoperability in which we're trying to bring some of the benefits of in-workflow integration that have been achieved in other industries, and we're going to walk through some of those in just a minute, into the healthcare ecosystem. Although I've always had my hand in interoperability, I've had the good fortune of also seeing a lot of different parts of healthcare. So I've always had my fingers in interop, but being on other parts of the components with care management, clinical management, those types of things, and helping design some of those systems, which are very closely related to interoperability, or at least very dependent upon it. Now, although I certainly am an employee of Humana, I do quite a bit of work from an industry perspective. I am on the coordinating committee and architecture group with the Da Vinci Project. I'm also one of the co-chief architects for the Fire at Scale Task Force with the ONC, and also other groups such as the Caring Alliance, the Argonaut Project, and a few others. There's a lot of HL7 accelerators and other groups that are bringing great work forward. We're going to discuss some of those today, but this is going to be from a lens of the healthcare space, not any specific actor. So with that being said, I'm going to define one thing really quickly, because from my vocabulary perspective, integrated care delivery is just intuitive, but I want to make sure that folks understand what that means when we talk about integrated care delivery. And what that really means in terms of what we're discussing today is summed up in a few words: right data at the right time in the right workflow for the right outcome, right? And as we go to the next slide, I think folks on this call probably appreciate that we don't always have good cohesive interoperability as it relates to exchange of clinical information, right? And we're going to set the stage with some examples of that. We're going to talk about things such as fundamental understanding of APIs. I know that some folks on the call may already be experts in that type of technology, but we do want to set a foundation of what APIs are and how they enable the capabilities that we're going to walk through today. We're going to do a foundational understanding of fire, or knowledge discussion on fire, understanding, again, not so much from a computer science perspective, although I would love to do that in a different session, but mostly the business and capability and enablers that it brings to the ecosystem. We're going to look through some practical examples, right? The technology is great, but showing it or representing it as a business case is really, really key, because one of the things that we want to make sure that you walk away from this session is not just understanding what fire does from a technical perspective, but the types of use cases and the types of capabilities it brings to bear, so that you can evaluate, hey, should this be on the roadmap for our organization? Maybe you have to because of the CMS or ONC regs, but also to think of it only as a regulatory issue is a little bit myopic, right? So we want to make sure that you have an understanding of the capabilities and things that this technology brings to your organizations. And also we're going to talk about the HL7 accelerators, technology, the community involvement, use cases, and should your organization be evaluating it? And if you should, an approach to make that successful. All right, so with that being said, we're going to do about maybe 60 minutes of slide walkthrough here, maybe a little bit less. I've got several slides here, but some of these will go pretty quickly, and then we'll save the last 25 to 30 minutes for an interactive session. I think Denny is going to be monitoring the Q&A, so if there is a question that is just burning and cannot wait, we will absolutely address that midstream if it's something we need to address before we move forward, but probably for the majority of the questions, we will hold those towards the end.
Very good.
All right, Lynn, if you wouldn't mind going to the next slide, that'd be great. And I know that, folks with the consortium are probably very familiar with the challenges that we have in healthcare interoperability from a clinical perspective, but let's make it real, right? And although this study is a little bit dated, it really sets the stage for the operational or the use cases, or the opportunities, maybe is a better word to say it, for the type of interoperability we're going to talk about today. Now, this study was a partnership between Humana and the University of Pittsburgh back in 2019. It was published back in October of 2019. And as you can see from the headline there, it clearly indicates that there is a significant amount of waste in US healthcare, $935 billion, right? And that's probably not news, or even I think folks grasp that without seeing it in a headline here. But one of the things that is really key for what we're talking about today is on the bottom row there, you see that about 25% of that almost $1 trillion is relatable to failure to have insurer and clinical collaboration and data interoperability. Right. So from a financial perspective, you see up to $282 billion being wasted because of inefficient or non-existent interoperability. And that's a huge financial cost. But even more importantly, convert that into human cost, right? The fact that physicians are not getting information they need when they need to get it, which translates into less than stellar, member or patient experiences. So again, it's a huge issue from an administrative perspective, but equally, or probably even more important, is it's easily translated into inefficiencies, abrasions, less than stellar experiences, and less than optimal outcomes from the folks that are dependent upon us to help ensure their healthcare is right where it needs to be. All right, with that kind of setting the stage, if we could go ahead and go to the next slide. I want to do a couple of definitions, and I know this is probably very, very obvious, but one of the questions we occasionally get is, hey, Patrick, what are you really talking about? Because in healthcare, we've been exchanging data for 50 years, and that's true. We have been getting information from point A to point B via some format for more than 5 decades, probably. And that's great, right? That maybe have served a purpose many, many years ago. But the problem is these are typically or historically communications that were built for purpose, were very, very difficult to implement. Reusability and standards may have been talked about, but yet again, they were very, very difficult to implement. And a lot of times we basically had one-off or single purpose implementations. That's not what we're looking at in today's world of interoperability. So if we go to the next slide and we look at truly what interoperability means, I like to say it's not your father's data exchange, right? In the sense that what we're trying to get to with this is cross-organizational, cooperative, integrated sharing of information across organizational boundaries. And that is predicated on easy to use, reusable, industry adopted standards. In previous versions of what we'd all did from an industry hit parts of that, right? There may have been some standards, but they were really, really difficult to implement, or they were open to interpretation, or other things that made their ability to scale across the entire ecosystem. I'm not just talking about two actors or a segment of actors, not just EHRs, not just payers, not just population health. They all have tools that allow them to communicate with each other. But the ability to share information across the ecosystem using a true interoperable standard. And what we're really trying to get to is a very, very simple diagram on your right side there. But what I like to call is the hyper-connected ecosystem, right? In the sense that we've got actors from across the spectrum. I know it's a little bit of an eye chart there, but you got medical devices. We're going to see or talk about an example of that. You've got providers, you've got patients, the patient access API we're going to talk about in a second. You've got payers, employers, others that using a common standard over time will be able to share information. Now, I know that's a lofty goal, and we often get the question, why now? What is so different in what we're doing over the last 4 to 5 years or whatever the case may be that's continually taking ground, right? Well, having tried to do this or been in this space for many, many years, I can tell you that things are different now than they were historically. Some of the conversations, some of the partnerships, some of the cooperation that we have across the industry was unthinkable 10 years ago, right? And a lot of drivers of those are the fact that we've got a common interoperable framework, namely FHIR and some complementary technologies that allow us to share information. We've got value-based care models between payers and providers that help illustrate the fact that without sharing of data, you don't have optimal outcomes, right? That's been a really big driver for this, the need for integrated care delivery, right? The fragmentation that we have in healthcare can be very much mitigated or improved with having the right data right when it's needed. And we don't have that in today's world. We've got some industry cooperation and consortiums, as considering this one also as well, Massachusetts, which is bringing folks together to make this happen. Also setting standards. Denny did a great job setting the stage of the things that this group is doing. And think about that even on a broader scale, right? We do things from a cooperative perspective that enable these partnerships. We've got empowered consumers, folks that are now have FHIR-enabled devices that allow them to share information. We've also got regs, from CMS and ONC that advocate and mandate the use of this type of technology, right? So a lot of things coming together. I like to call it the inflection point. I know that's a little bit of a blasé term at this point, but things coming together to make this a ripe time for the sharing information using the type of approaches we're going to walk through today. Next slide, please. Now, I know this particular slide is very, I'll use the term, it's a crayon slide, right? It looks like it was drawn with crayons. And I get that, but it really does tell a good story. Although it's very simplistic, almost childlike, it tells a good story. And if we look in the upper left corner, we see that we've got, looks like a clinic, maybe on the left side, and on the right side, maybe a health plan or a hospital system or whatever. And then we've got these vehicles going between them. So work with me in your imagination and think of those vehicles as use cases. Pick whatever use case you like, prior authorization or quality measures, whatever, lab results. And you've got roadways that are going between those entities. Unfortunately, what has happened between those two actors is that for each use case, the roadway was built again, right? So for the bus, the van, the scooter, and the car, at low scale, this works. You can get information point from the left to the right and the right to the left, but it doesn't work at scale, right? Because there's not a shared infrastructure or a shared set of capabilities to enable these vehicles to go left to right or right to left without building their own roadway. But if we look in the lower right corner, we have a much different picture. We actually have the same clinic on the left, the same health plan or hospital on the right. We got the same vehicles, the car, the van, the school bus, and the little motor scooter, but they're all using a shared infrastructure, right? They're all agreeing to the rules of the road. There's a stop sign. There's a sign that says this way. There's lines in the middle of the road. Vehicles are not crashing into each other. They're not rebuilding the roadway each time they're developing new use cases. It's the same information going back and forth, the same use cases, but it's a much orderly framework that everyone has agreed to. The other key thing about the lower right picture is that you can develop a new vehicle, right, or a new car, a new use case, pop it on the roadway, and you're in business, right? You're not rebuilding the ability to share information via different protocols every time you have a new use case. You're basically taking the Lego blocks that we're going to talk about in a few minutes and sharing information across the ecosystem. Next slide, please. All righty, so again, I'm going to go through this. If you're expert in APIs and FHIR already, this will seem very redundant to you. To make sure that we have a great baseline for everybody that's joining us on the call here today, let's quickly talk about what an API is. And the reason we like to cover that is that the term API, or application programming interface, almost takes on like a Harry Potterish type dimension in today's world, in the sense that everybody talks about APIs. Everybody's, API this and API that. There are a lot of publications. Folks love to talk about APIs. But the cold hard truth is that APIs are not new, right? Many of us who have been in this space for a long time have been using APIs going back to the 70s. Now, they weren't web APIs, and that's typically what we talk about here. But in reality, an API is basically an intermediary, a software, or a piece of hardware that allows applications, servers, devices, or whatever to share or access other applications, capabilities, or data, right? It basically allows two actors in healthcare, or two actors not in healthcare necessarily, to be able to get information, put information, or access functionality from a remote system, right? That's basically what an API is. And I'm going to give you a really cheesy example from another industry, but it tends, for folks that are maybe not quite there in understanding what the capabilities of an API is, this may help. And I'll give you an example, and I'll use myself as kind of the actor in this, right? And back when we would go to the office pre-pandemic, I typically did most of my clothes shopping walking from my car to my desk in the morning, right? It's color, size, and buy, and it shows up 2 days later, right? And that was a very easy experience for me, right? 40, 50 seconds, because I buy very basic stuff, and boom, it shows up. Now, behind the scenes, that was a completely API-enabled experience. There was a connection that was made via API to my bank to make sure that I had those $14 in the bank to pay for that 10-pack of socks. There was an API interaction to the shipping company, UPS, FedEx, Postal Service, whatever, to make sure they could get it to me. There was an API transaction to the warehouse to make sure that they had that 10-pack of socks in stock, and so they could get it to me. I didn't log into my bank and transfer $15 over. I didn't log into UPS to arrange the shipping, and I didn't call the warehouse to make sure they were in stock. To me, from my experience, that API allowed me to stay on a single screen and get exactly what I needed to get done in real time, in a very few number of strokes, in very limited time, right? Compare that to what we historically do in healthcare, where things such as chart chase, prior authorization, any use case you can come up with, they're typically not that nice, seamless experience, okay? That's where the opportunity is. And that's where we shift from what just as an API is to let's talk about what FHIR is, or the Fast Healthcare Interoperability Resource. Now, Denny mentioned earlier on some very stable technologies that have been around for years. For example, the HL7 V2 messages, ADTs, ORUs, and things that many of us are very, very familiar with. And also, the CCD formats, which most of us are probably comfortable with as well. For the purposes of today's discussion, I'm focusing on FHIR as a workflow integration and a data model. So we're not specifically going to talk about V2 or CCDs because transparently, FHIR enables, they serve what they need to do very, very well. But FHIR enables a whole new level of innovation and interoperability that you just don't get with previous versions of HL7. I want to pay my respects to previous versions of HL7. I'm a card-carrying member of the HL7 community, but what we're trying to get to from a workflow, real-time integration perspective is more easily achievable using contemporary technologies such as FHIR. Now, so what is FHIR? If I distilled it down to just a couple of sentences, FHIR is an API model and a data construct that is designed for healthcare, has been vetted with the healthcare community, and the healthcare community is moving towards this. So we talked about what an API is. We used an example from a different industry, but FHIR brings that type of ease of use, that type of common format as an API and a data model for healthcare, right? I know that's distilling it way down to very, very basic stuff. So I'm going to give you a couple of analogies to maybe drive this point home. The first is, think of these as almost Lego blocks, right? And we start looking at some of the use cases that are coming together from an industry perspective. It's helpful to understand the underlying constructs of FHIR. For example, you've got an API and a data construct, which represents a member, or a patient, I should say. You've got an API and a data construct that represents a medication or medication request or whatever, observation, lab result, claim, questionnaire response. So of the 161 different fire resources they represent a logical or physical data element or data construct that we use in healthcare. And these things can be put together to create more complex things as Lego blocks would to build use cases. And we're going to get into some of that in just a second when we talk about the accelerators. The other key thing that I want to make sure that I emphasize is that the ability for standardization and reusability. And again, I'm going to give a really cheesy example, but I suspect during the session today, there's a lot of folks watching this on a laptop, right? And if you get up and move to a different room or you want a change of scenery, you pick your laptop off and you walk into the room, and if your battery's low, you just plug it into your wall. That is a reusable plug, meaning that the 110 thing that you use to plug into the different things means that every time you go to different rooms, you don't chuck out a piece of your drywall and tap directly into the electronic wiring behind the wall. You're using a pre-usable component or reusable component that's been developed and which has been adopted across the house building industry for many, many years. That's what we're trying to get to from the perspective of what fire does. We don't want folks to have proprietary or one-off solutions or things that are customized, right? Not talking extension is okay, but not customization, so that everybody that agrees to participate in the fire ecosystem can share information without having to have pre-knowledge or specific actor knowledge of any other actor in healthcare, right? So if you're dealing between a provider and a payer, right? The implementation should be follow the standards so that those entities can share information without spending 6 months or a year on the phone agreeing on formats and blah, 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 like we used to do many, many years ago. That's the secret and the power of what we're trying to do from a fire perspective. Alrighty, if we could go ahead and go to the next slide, Lynn, I'm going to give several variations of this because I really want to drive this point home so that when folks leave today, they understand, the capabilities and the opportunities that are before us as an industry. So if we look at on the left side, again, very simple picture, and I think we've covered most of this. Fire provides a technical framework for connectivity, right? It's actor independent, meaning you can be a provider, you could be a member, a patient, you could be a research community, you'd be a medical device, you could be a payer, you can research, whatever. As long as you have the appropriate consent and authorization, and as long as you follow the rules of the road for exchanging fire information, you can participate in the ecosystem. And that helps build what we see on the right side, because the technology and the framework is only half the picture. What really brings this to fruition is the community connectivity, meaning folks of a like mind that are meaning to solve similar use cases or the same use cases in their specific domain, coming together as a community to agree that, hey, we're going to use fire. We've got the Lego blocks. Now we can build implementation guides and or solutions or whatever reference implementations to solve problems that as a community need to be solved. And I could spend 3 hours talking about every one of the groups on the slide here. I'll just go over a couple because we're going to talk about HL7 accelerators in just a second. I'm going to start calling a few of these out. So if you look at the 1 o'clock position, you'll see that there's something called the Gravity Project. And yes, we have very creative names in the fire community. I don't know why, but they're just really, really creative. So we've got what we call the Gravity Project. And that is a group of folks from across the spectrum of healthcare that have come together to look at social determinants of health. What can we use from a fire perspective to help solve or realize the opportunity of capturing SDOH, sharing SDOH, and using it to appropriately provide the best care and the best recommendations for patients? That's what they focused on. At the 3 o'clock position, we've got the Argonaut Project, which is kind of the grandfather of the HL7 accelerators. I know you've got a niche, I think, coming next week. He could talk about this for 5 or 6 days without taking a breath. But
we also have Mickey Tripathi, who is our colleague and
absolutely
led the Argonaut Project for a long time.
Absolutely. And so, the Argonaut Project typically focuses on core data services from an EHR perspective. So that's there, and I participate in that as well. That's our focus from an Argonaut perspective. We've got the Da Vinci Group, which we're going to talk about a little bit later as well, and that's in the 5 o'clock position. The Da Vinci Group is a group of folks from the provider, the payer, the vendor community, HIT vendors that come together for value-based care, things such as prior authorization, sharing of member rosters, quality measures, those types of things that facilitate the exchange of information, putting those FHIR Lego blocks together to solve or to provide implementation guides for the value-based care arrangement. The Care and Alliance is another one that is very prominent in providing some great solutions as it relates to consumer mediation. And their focus is basically when patients have the power of the supercomputer in your pocket and they can give consent to share information, how do we create the implementation guides that says, yep, we're going to use FHIR, we're going to use consumer mediation and share that information where patients want it, right? That's a lot to do with the Patient Access API, which many of us have been involved with for the last several years, which is up and running at this point. But again, providing solutions using FHIR in a consumer mediated way. And the last one is up in, not the last one, but the last one for descriptive purposes here is in the 11 o'clock position. That's Codex, that focuses on using, again, the FHIR infrastructure, the FHIR vocabulary for solving cancer-related use cases, right? So again, technical framework, which the community adopts, then using these Lego blocks with folks of similar intent or similar background or similar passion or mission to solve use cases. That's where these HL7 accelerator groups come together to help bring solutions to the market. And again, they're not specific to any one actor. They're developed from a community perspective. They're given back to the community in general, and they allow us to solve common problems in which we don't need to compete on formats and protocols. That just makes no sense in today's world. All righty, if we could go ahead and go to the next slide. I'm going to quickly, talk about, as a public service, we've reduced the 968 pages of the CMS and ONC rules over the last 2 years as it relates to the Cures Act and the Patient Access API into a couple of key points. And the reason I want to talk about this is, I know this is a little bit dated. People have been working on the Patient Access API for a while. It's in production. The ONC rule has already been in production as well. And I know there's some dates out in the future. But folks, if you're in that space, EHR space or a payer space or a third-party app space, you're very, very familiar with these. But it is beneficial to repeat some of the key things that these rules were trying to advocate for, right? And because it's going to kind of solidify or bring another lens on some of the use cases that I'm going to talk about in a little bit, and also provide some fodder for an argument or something I'm going to advocate for later as it relates to considering this not to be a technological floor, but to provide a mechanism for advancing your organization. So some of the key things that come out of these two rules. In fact, the first one is member empowerment, right? The fact that historically consent consent is always a big issue, but prior to the Patient Access API, sharing information typically followed very classic models of health plan operations or member consent via an EHR or some other mechanism to capture consent. But with members being able to basically click a few buttons on their mobile device or on a web page and authorize sharing of information, that consent model is changing things, right? It truly is putting patients in control of their data. The fact that it's standards-based in open APIs, that basically means FHIR using open APIs, standards, and that agreed upon data construct that I talked about, right? So we've covered a lot of that. Care coordination across payers and providers. Don't want to let this one go, unnoticed, because it really is a different way of ensuring that folks can move through the healthcare ecosystem and take their data with them. Let's be transparent. In a lot of cases in today's world, if you move between organizations, it's almost like hitting the reset button, right? You've got to have claims flowing again. You've got to have, onboarding experiences. You typically you don't always have the benefit of nice longitudinal records to enable a nice, smooth onboarding experience. And the last one there is innovation. Hopefully some of the use cases I'm going to show in just a few slides are really going to resonate with you guys, or at least show you the power of the innovation. But the fact that, in healthcare, we tend to have a little bit of a reticence or concern about innovating, or maybe historically have. But given the power of the technology that we have and the fact that other industries have used this to great success, and I know that in healthcare we have a higher bar because we're dealing with folks' folks, healthcare information, totally get that. But that doesn't mean that we can't use these standards to provide better solutions for providers and patients, and make sure that that we're providing data in standard formats and standard APIs, so that folks that are coming up with new and innovative ways to visualize data or provide insights to information, so that that patients have the benefit of the latest and greatest technology, analytics, machine learning, or whatever. We want to make sure that we are enabling that. All righty, next slide, please. Okay, I think folks have probably seen this historically, but I do want to call out that we're kind of in a middle state here. As of July 1st, many of us that were under the the patient access API rule had our API standing up. Those are currently operating at this point, but that is not although it was certainly a milestone, it was not the top of the mountain. And that's going to continue. We're going to keep going based upon regulation, but even above and beyond regulation. That really is a baseline. The technology that we're walking through here today enables a lot more than that. Now we're in between, January 1, 2021, which wasn't the enforcement date, but the official date for the patient access API, and also the payer data exchange, which is coming up. It's not going to be enforced again on 1/1/2022, but at some point it is, and many of us as organizations are going to proceed with that. And again, putting patients in the ability to use this new technology in innovative ways to share information across the ecosystem. And I would suspect that this is not the end of this, based upon the velocity at which FHIR is being adopted across the industry, and the advocacy that CMS and the fact that they have basically indicated strongly that they support the growth of this technology. I think you're going to see that arrow on the right side just keep going on in future slides that we haven't fully seen yet. So with that being said, if we could go ahead and go to the next slide and talk about some actual examples of how this technology comes into play, right? What does it really provide? What are some tangible benefits from this? But before I jump into this, I do want to give a quick perspective for those that may be relatively new on the journey of FHIR, or considering it, or maybe you're not under the auspices of the federal regs, or just kind of confused or not sure about how to think about this. And my advice would be, as somebody that my organization has been a proponent of FHIR-based interoperability for many years. We still actually have a STU1 API in production, which still serves up information to this day. Yes, it needs to be upgraded. I know that, but this shows you that that we've been doing this for a while. And the only reason I say that is because I want folks to understand that thinking about FHIR and these complementary technologies only as a technical solution is a little bit short-sighted, I think, if you're thinking about it this way, at least from my perspective. It certainly is an underlying technology, but you've seen the fact that communities have come together to solve use cases, but also as an organizational perspective. We've seen our organization and many others benefit from the fact that don't consider this just to be technology, right? This is an operational or organization enablers, right? It's just not a technical have to do. And this is going to, hopefully when we go off through these examples here in a second, really resonate with folks, because what we've tried to do, and what I would advocate for folks, is don't keep this in the IT shop, right? The evangelization of the message that we've got new capabilities. We can do things in workflow that we couldn't do before. We have the ability to build apps and serve those up in remote workflows, or get information, or do subscriptions and publications, things that may result in different ways of thinking, right? So it may not be obvious to folks that are making operational decisions or business decisions, or whatever the case may be, that they have a set of tools that are coming to bear. They could potentially have them think differently, right? And if they start thinking the ways of, how do I use this, as opposed, I have to use it, but how can I use this to really move the business forward, or the clinic or the operations forward, that can show a lot of value. Now, the road that many organizations go down is one in which you certainly have to incubate the technology, but at the same time, you're evangelizing the message. You've got the technology that's being built up. You've got the use cases that have been cultivated, and showing, basically some good results there. One of the things that we did early on is, as opposed to just saying, hey, we got fire, it's a great technology, we should all get on board, was going out and finding use cases both internally and externally of where we could show value, right? And some of those are going to pop up here in a second, but that's how we started getting adoption across the organization and with a lot of our partners that we have in the industry. You know, as a technologist, I'm very proud of the technology when we bring it to bear, but I will also say I'm equally as proud of, you know, when our executive team started, posting on LinkedIn and giving podcasts or whatever about the power of API and fire, that really resonated with me, that the message had been evangelized internally, and we were certainly on the right path. Now, what we're going to walk through here, these examples are limited by time. We could go through a lot more, so this is not a holistic message or holistic list. But, you know, as you're after the session here today, I would encourage you to, you know, go jump out there, look at some of the examples. You can Google it, hit the hl7.org, whatever, DaVinci, Karen, Codex, the Fire Scale Task Force, and you'll see examples, much broader examples than what I'm going to describe here. But these are some that are near and dear to my heart. So we could go ahead and go to the next slide. We'll first talk about prior authorization, or utilization management, as we sometimes call it. And the reason that I like to go through this one, because out of all of the use cases that we have from a fire perspective, this one is very illustrative of how we bring true value to a process using this new process and approach, right? And I will be honest, I initially implemented the X12 HIPAA 278 transactions many years ago. So this one is near and dear to my heart as far as removing some of the abrasions that the prior authorization process brings to bear. Now, I know this is a lot of an eye chart, and I'm not going to go through it line by line, but you can obviously see by the red X's, and you know that there's a lot of fragmentation in the prior authorization process. A couple of key things are, a lot of this is out of band. So folks are jumping out of their EHR system, they're making phone calls, they're using fax machines, they're logging into web portals, they're looking at Post-it notes. So it's out of band, out of process model, right? Which is never good. Also, studies show that it takes about 18 minutes for a prior authorization process to come from a clinical, from the physician side or the provider side, from start to end, right? That's a really long time, 18 minutes. And that, again, goes back to the phone calls, the fax machines, out-of-band processes, probably a little bit of profanity thrown in there, given all of these out-of-band processes. And that's just really not acceptable given the technology that we can bring to bear today. So again, if we go ahead and go to the next slide and talk about, as opposed to faxes, phone calls, you know, doing a prior authorization because you're not sure. We see a lot of that. Folks are not even sure if they need it, so they'll go ahead and do one just to cover the base. What we're trying to get to, and part of this runs today, and I'll highlight some of that as we walk through here, and this is a DaVinci use case, for example, is how do we use this technology to bring the data and the process into the EHR workflow, right? And this is how it works. Again, today's world, out-of-band process, it's something completely separate from the EHR. What we're getting here is basically a three-step process. When the order is being signed or being requested or whatever, there is a behind-the-scenes process which fires between the EHR system and the payer that starts the handshake and says, hey, I am provider X, I've got patient Y in my office, and I'm about ready to do this. Payer, is there anything special that we need to take into account? Is prior authorization required for this, you know, referral to an orthopedic specialist or this procedure or whatever the case may be? Very simple concept, completely API enabled. So actually called a CDS hook, a care decision support hook, right? Which was born in, you know, the clinical decision support world, but it has been matured so that it can interact between an EHR system and a payer, right? And in real time, the payer will respond back with a response or a CDS card, which is basically an indication or an answer to the question that's been asked. And I know it's really small on the screen here, but it basically is a response that says prior authorization is required for the service, right? And in this case, it came from Humana, which happens to be the payer in this particular use case. So in today's world, that is a cumbersome process. Literally is a phone call is, post-it notes or whatever. And for those that are prior authorization or referral specialists on the call, you probably really appreciate that. But in today's world, or in the world of the future, meaning a couple of months from now, from my perspective, is that will be an automated interaction that is facilitated by something that the referral coordinator or the physician clicked in the EHR. API goes behind the scenes, interacts with the payer, and brings the information back. So prior authorization is required. That is a step forward in terms of functionality or operational efficiency on the provider side of the world. The second part of the piece is that what if we have the scenario in which the payer needs some type of medical necessity documentation, or if they there's something else needed, and that happens. About 80, I'll pick on my company, about 87% of the authorizations that we do are approved first pass, meaning within about 4 or 5 seconds. But for 13% of those, there is some specific piece of information, diagnosis code, whatever, that we need to make sure that we understand what the authorization is all about. Now, we would prefer that happened directly in the workflow, as opposed to us sending a message back, we'll call you later, or fax your information here, because that's just an out-of-band abrasive process. In this model, there is a little hyperlink that pops up right inside of the EHR that says, we need a little more information, please click here, right? And you actually see it if you look in the blue box where it says, in step number 1, there's a link there for medical necessity documentation. That's the link that is clicked and brings up box number 2. And this is completely fictitious information, but basically is based upon what you're describing, tell us what the diagnosis code is, the symptomology is, right? The provider or the referral coordinator clicks that. Now we have enough information to automatically submit the authorization, which is a required HIPAA transaction in 278, which happens in step number 3, meaning that behind the scenes, a good old-fashioned, shouldn't say old-fashioned, it's still very appropriate, a HIPAA 278 X12 transaction is created and then submitted, or actually, I shouldn't say that. It is a FHIR bundle, which is created on the EHR side of the world, sent over to a clearinghouse, then converted into a HIPAA X12 transaction. It could be FHIR, could be X12, but in this case, let's say it's FHIR. Bottom line is, it's a lot easier for the provider system, or the referral coordinator, because it's all done automatically. So as opposed to phone call, faxes, whatever, you got a 3-step process in which the provider or the referral coordinator never left their workflow, right? Some of the studies that we've shown takes the 18-minute process down to about 2 minutes, something like that, if it's embedded in the workflow. And it's a much less abrasive model. And, it's a dramatic improvement. Other studies show that, I know a single practice, single provider practice is very unusual in today's world, but if you use that for a baseline, prior auth is about a $40,000 a year incremental cost because of the time and the abrasiveness of it. Using a model like this allows us to bring that abrasion and that cost of getting the authorization much down. If we could go ahead and go to the next slide, let me show you what part of that actually looks like in a real workflow. So I took these screenshots. So again, this is a Da Vinci use case, and I'm going to talk about the technology and then talk about what this does from a workflow perspective. So we've been talking about FHIR for almost 38 minutes at this point. And it provides the APIs and the data construct to enable the workflow integration that I've been talking about. There's also another complementary technology that allows third-party apps to be built upon these FHIR APIs. And the power of this model is that third-party developers, in this case, it was Humana. It doesn't need to be Humana. It could be any third-party developer. In most cases, or the preference would be that it's completely payer agnostic. We don't necessarily want Humana-specific solutions, but allows us to serve up these questionnaires directly in the workflow. So if you think about the prior auth perspective, in which prior auth has been requested, we need a little bit more information, and we're able to pop this questionnaire up directly in the EHR while the referral coordinator or the physician is doing it, get the information that we need, and then move right along with the process. Is quite a big efficiency. And that's what this is. So think of these apps as, things, for example, if you ever download an app on your phone or whatever, iOS or Android, it's a similar concept, not exactly, but similar in that these apps can be available in the different app stores that are available with EHRs, whether it be, the App Orchard or some of the other stores that are out there available. And then these can bring additional functionality into the EHR workflow to remove abrasions and make things go better. If we can go ahead and go to the next slide, please. Let's talk about, we talked about some of those use cases, but one thing I didn't talk about a lot is, for example, Da Vinci membership. My organization, of course, is a big proponent of Da Vinci's interoperability in general, but it's remarkable some of the names and the groups that have come together, as you see on the slide here, from a provider perspective, industry partners, EHRs, vendors, payers that are coming together to agree on which Lego blocks we're going to put together to solve some of these use cases. So I use this, to show you the pedigree of some of the folks that are involved, but also to maybe encourage you if you're not, engaged in some of these groups, but you like what you're hearing, or you think this would be a good place to put some focus, then feel free to, you can certainly reach out to the different community folks and see what your place or what your role or how you could participate in some of these. If we can go ahead and go to the next slide. Let's, I've talked about a couple of use cases, and I've actually got some more use cases to talk about. But again, I don't want folks to think these are very narrow. Again, if we go back to the slide we saw many, many, many slides ago, the fact that they're typically domain focused. What are we trying to solve? Value-based care, cancer, whatever. And this is just one example of things. For example, coverage and burden reduction in the lower left corner. That's what I was talking through from a prior auth perspective. We got quality improvement. So that EHRs are providing information to payers and vice versa, so that we know we can close gaps in care, quality measures, whatever. Member access, we got the patient access API. I could go on and on and on. Clinical data exchange, that deals a lot with making sure that payer data is available in the EHR, so that there's a nice clinical summary. We could literally spend the next 5 webinars that Denny is hosting here talking about some of these use cases. But again, just keep in mind that perspective is specific to the like-minded trying to solve a problem, but there's a lot of use cases out there, and I'm just hitting a couple today. Next slide, please. All right, I'm going to hit you with another example, something that that is going to be on the plate if you're a part of the payer community. Even if you're not part of the payer community, there should be this use case may resonate with you for other types of uses, right? And one of the rules that we talked about previously with 9115, the CMS rule, is that as part of care coordination, when members go from one payer to another, if you're, Medicare, Medicaid, CHIP, whatever, anything governed by CMS, is that you can elect to have your information sent from your old payer to your new payer, so that you're not basically setting the reset button, your medication list, your conditions, authorizations, other things that the new payer needs to know to make sure that you're getting the appropriate services will be much faster, much smoother than it is in today's world. Guess what? That is so much easier to facilitate if the old and the new payer are working from a FHIR perspective. Because as you can see in I know it's a little bit of an eye chart there underneath the two organizations, you basically have US CDI. So the content that we've agreed to and that the ONC has put as part of the standard is what is defined as the information which must be shared from the old payer to the new payer, right? FHIR supports that. US Core is based upon US CDI. So there are FHIR standards that basically represent the US CDI data within FHIR objects. That was initially implemented in the patient access API that I talked about a few slides ago. It's being reused when we talk about payer-to-payer coordination. So again, you heard me really harp earlier on the fact that we don't want fit-for-purpose solutions. We want to put these Lego blocks and these things together so that we can reuse these across the spectrum for different use cases. This is an example of bringing that to bear. Alrighty, if we could go ahead and go to the next slide, please. I'm going to talk about, we're getting kind of close to the end here, but I do want to talk about some complementary FHIR implementations, because I've been talking about some of the bigger ones, prior authorization, payer-to-payer, patient access API, but there's other things that are very amenable to using this type of technology as well. I'm just going to give you a couple examples that are out there and that we've implemented and have had a great success with. The first, and these appeal are very modest, but they add real value to workflow. The first is what we call the medication profile, which is again using basically the medication components of FHIR, so that, or that when we have in-home physicians or nurse practitioners that are going into the home to do an assessment or to provide care. One of the things that has historically been a really big abrasion point is not knowing what medications that a patient is taking. And a lot of that was solved, or the historical way to fix that was, those gallon clear bags in which people put their medications on was, hey, show me your bag of medications. And the physician or the nurse practitioner would go through those. With this model, as the physician or a clinician is walking through the front door of the patient's home, there is an automatic FHIR API that goes between the in-home EHR and the payer to say, we are starting an encounter, give us the curated medication list. And that medication list is based upon claims that we've seen come through the pipeline. It also is augmented with pharmacist phone calls with patients to see if they're taking over the counter, whatever, going to the VA, and maybe there are not claims on that, but it's a curated medication list. So the clinician walking into the home is going in from a position of knowledge, right? They understand, or at least have a really good foundation of what medications the patient is taking. And on the tablet device, they're asking, you still taking this and this and this? And, oh, you're taking something else, and they're updating it. So that medication list is then pushed back to the plan as well. So there's complete synchronization between the two. So our studies have shown that historically, if they show us the gallon bag, that's about a 25-minute exercise of doing med reconciliation. When you've actually got the meds on the tablet device and you're just confirming or updating it, that time is really trimmed down, and the clinician can more quickly shift over to other parts of the home visit. So that's really, really important. Another use case that we've been able to implement with a FHIR type approach is what we call a member task profile, which is kind of a goofy name, but it basically means that if there are hospitalists that are basically in the hospital and they're making sure that patients are ready for discharge or whatever, is that as they're going between the different patients, if there is something, a piece of missing information, for example, if the patient maybe doesn't have a PCP, or there's some reason to suspect there could be post-acute issues, maybe with food insecurity, or they're, maybe a ramp, or they live alone, or there's a transportation issue, is that in the hospital before discharge, the physician is armed with that information, and they can tailor the questionnaire to ensure that we're not going to have a post-acute event, right? Where a patient, can't get down because they don't have a ramp, they can't get down and get to the physician, or they don't have a PCP, so there's no follow-up scheduled, or whatever, right? Whatever some of those social things are, or housing things, that the physician can ask extra questions to make sure that we are setting the patient up for a positive post-discharge episode, as opposed to one in which they could be rehospitalized or have to go to the ER because they don't have the mechanisms to take care of themselves. The next one, which is going to be a really big thing, is, as all of these are probably, is remote monitoring and virtual care, right? So in these, basically some of the work that we've done is looking at folks with specific conditions, for example, maybe CHF, and basically using device data that is passing from devices into FHIR and coming into our FHIR infrastructure, so that we can determine, hey, is there a change in weight? Is there a change in steps per day or blood pressure, whatever? So as opposed to waiting for some to react to a negative clinical event, the clinicians are actively monitoring that data or getting alerts if something looks like it's trending in the wrong direction, so that they can take proactive engagement with members, get them into the office, make a phone call, whatever, to ensure they're getting information before it results in a really bad experience with an admission or something that could be avoided if we have the right data. Again, device to FHIR to analytics to a clinician looking at that information. All right, if we could go ahead and go to the next slide. Some of the emerging opportunities that we see coming. We've talked about the patient access API. Although adoption is very modest in today's world, we expect that it's going to pick up over time as patient becomes more empowered. Quality reporting, meaning taking out some of those abrasive, chart chase type things that happens in today's world, and using automated FHIR publications so that quality measures and lab results and other things, med reconciliation, whatever, excuse me, is being shared between the actors in real time, as opposed to making photocopies and fax machines. Burden reduction, we talked about that with the prior authorization. We talked a little bit of remote monitoring. SDOH, I think that's going to be a really big thing going forward. As you know, the research shows that SDOH is a really, really important component of a patient's overall experience, and making sure that we're capturing that from a fire perspective is going to be key. Pair-to-pair data exchange, we covered that. Integrated care planning, I think that one's going to be huge in the future when we start bringing together the PCP, the case managers, caregivers, neighbors, folks that are actually checking on people. So we have an integrated care plan across the community. Not everybody would have the same authority or access, of course. Clinicians or doctors would have the most, but the caregiver being able to update, yeah, there's food in the fridge, you know, they're walking around, that type of thing, to ensure that we've got really good, you know, community support for patients. In-home care, we've talked about that as well. With, you know, the trend towards in-home care becoming more and more prominent, we need to ensure that the in-home EHRs have the same access to data, like medications, clinical summaries, other things that enable those in-home physicians to be very, very effective when they're actually in the home, as opposed to spending half the appointment trying to figure out a clinical history, starting from a position of knowledge and understanding. If we could go ahead and go to the next slide, those were some, you know, we talked a little bit about functional use cases, right? And I'm going to close here with maybe a little bit of discussion on how do we do this at scale, right? So I'm going to shift gears just a little bit over the next 4 to 5 minutes. We've talked about functional use cases, prior auth, quality measures, payer to payer, pick your favorite use case, doesn't matter, right? But there is also a scaling component to it as well, right? We've got to be able to make sure that these transactions run at the appropriate volume and velocity that they need to. And that's where the Fire at Scale Task Force comes into play, right? So if we go ahead and go to the next slide, we can talk about bringing a lot of this together, okay? So we've talked about, you know, HL7, we talked about fire, we've talked about APIs, we talked about building blocks. We've also talked about these groups that you see in the upper left corner here with DaVinci and all those and the functional use cases. There's also another part of that component, and that is the Fire at Scale Task Force in the lower left corner, which deals with things that enables these other groups to be successful, right? So it's kind of like the plumbing. So things such as identity management, security, endpoint directory, intermediary exchange. Some of those things are very nerdish in nature, but are yet required to ensure that the other use cases can function in ways that they want to function. What we don't want to do is, for example, some people to be doing security one way, another group to be doing security another way, or identity management different across actors, right? Patient A in the EHR has got to be the same as member A in the payer system or in the population health system, or whatever your favorite actor is. That's where these technical components come into play. And if we go ahead and go to the next slide to close this out, you know, the FAST model, I think it's fairly intuitive. There are subject matter experts that deal with certain key subjects, such as identity, security, things that I've mentioned. We have coordinating committees, we have executive steering committees, and it goes through feedback processes. So what you'll find in the HL7 community is there is artifacts and there's information that comes forward, it's pressure tested, it's vetted, it's updated, and then it goes through a cycle of revision till we get to something that is very, very open for the industry. And if we go ahead and go one more slide, I think this is probably the last one or really close to it. We can talk about the life cycle of a couple of transactions. So Lynn, I'm not sure if you could go ahead and go to the next slide there, but I want to, yeah, if we can go to one more, I think we can skip over this one for a second and talk about the fire transaction journey, right? And so I know this is at least the fourth eye chart in the session today, but I want to bring all of this together, both from a functional use case and from an infrastructure or capability perspective as well. Now, in this particular use case, we'll see that we have, it looks like on the left side, we've got a patient and a PCP doing a visit there, and it looks like the PCP needs some information from the payer, right? That's a lot of different use cases. But you could choose any use case you want, any two actors, it doesn't matter. It doesn't have to be a payer, could be a specialist, could be pop health, whatever, CDC, whatever use case you want. What we see, though, is that there's a similar set of capabilities that are needed to ensure all this runs at scale. First of all, you can have those Lego blocks, the fire resources, but you also have to have that roadway that we talked about really, really early in the process. because as the requesting system, in this case, the EHR, it needs to know how to interact with the remote system, in this case, the payer system. It's unlikely that each one of us wants to have a local configuration file of every other endpoint in healthcare. That's really not scalable over the long term. What we're trying to do in step number one is have an available endpoint directory so that all of the actors in healthcare system can look up, basically use a query to determine what the endpoint is, the fire server for another actor. That's step number one. Step number two and step number three is basically making sure that we've got the appropriate identity agreed upon. So that patient A in the EHR is the same as member A in the payer system. We've also got things such as we talked about directory and exchange. If there's any versioning between different formats of fire, if it's going through an intermediary such as an HIE or a clearinghouse, we need to ensure that the protocols are in place to ensure the delivery of the message. And then it gets over to step number 6, and the response comes back in step number 7, and the entire process repeats itself. So I know, again, it's a little bit of an abstract concept, but you've got the functional use cases that we've been talking about, depending upon the underlying core capabilities of identity and security and piloting and conformance and certification to ensure that we can bring all of this together from a large scale perspective to deliver the experiences that we need to ensure integrated care delivery. And I think if we look at one more slide, this will bring us home. And we've got, basically a high level conceptual architecture of how that fire at scale task force works. And the key component of this one is that we realize these are very grandiose concepts as it relates to some of the things that we've discussed from identity security, that type of thing. But the goal here is to have implementations that can be rolled out when they're ready. So they're independent solutions. They're decoupled from each other. Together, they bring a very much of a synergistic impact, and they work very nicely together. But you can certainly roll out the security protocol, the exchange across intermediaries, identity, the national endpoint directory, and other capabilities that are needed. Because let's be honest, it takes a while to write the implementation guides and get these going forward. But that is what the goal is as it relates to the work that we're doing from a community perspective in HL7. So with that being said, I think we are at the end of our discussion and we can go to a question and answer.
Well, Patrick, thank you. That was that's outstanding. We talk about this all the time, and it's rare that we get an expert and a long-standing expert giving us the lay of the land. I was working with our team at MHDC this morning on our newsletter, and a small piece that I wrote was about sometimes I feel like I'm, a protester, waving a banner that says, liberate the data or adopt FHIR APIs or what have you.
Yeah.
But when we look around the country, we're seeing, for one, Apple has just changed their operating system and enabled consumers to choose whether or not they want their data to be shared with third parties. And the impact has been enormous. The ad revenues of Facebook are likely to take a hit. The ad revenues of Google are likely to take a big hit. Yeah. And we see legislatures around the country adopting, consumer-directed, consumer-mediated networks for not just health, but for a lot of other, major processes in their lives. And so it does sound grandiose at times. Other times, I think it sounds like it's upon us and we're almost there. We have a number of other questions that have come across the transom. I'm going to start. I had a little technical difficulty and had to sign in and sign out and then sign in and sign out again and then back in again. But I'll start and then I'll ask my colleague Janice Karen to pick up the questions that she has compiled from the audience so that we can give you the full gamut of what we offer and what you've elicited from them. First, we will have a copy of the webinar and the presentation on our website, probably in 3 or 4 business days. So for those of you who have access to our website as members, we can provide guest access if you send us an email and allow you to access the information as well. So yes, we will have that. One of the first questions I get is from Jason Ryan, who asks, identity matching is still a huge challenge and a barrier to adoption at scale, especially given the penalties for the inappropriate sharing of PHI. What's the timeline for the ONC Identity Tiger team delivering their initial recommendations to address this? What do you think these recommendations will be? And how do you at Humana deal with these identity related issues?
No, that is a great question, and very true. Is that identity is one of the biggest barriers, or identity management, identity resolution. It's one of the biggest barriers that we have to realizing fire at scale. And let's talk about the timeline perspective, because it is a absolutely a non-trivial issue. So the Fire at Scale Task Force, the identity management team, has been going for 3 years at this point, a little bit longer, 3.5 years. There is within the HL7 community, and I would encourage you to we're not going to be able to go in detail here today, but after the meeting, please check this out. There is a draft, or a PSS and a draft implementation guide that is currently going through the HL7 process. It was originally slated, I believe, for balloting beginning of next year, but given the complexity of the issues, I think it's been deferred a little bit. And it goes through. So if we talk about from a timeline perspective, I suspect we're still years maybe from a solution that's truly scalable. I think some of the less difficult models to implement, for example, in today's world, a lot of the exchange is done with collaborative patient matching, which means that I will share information with you if you give me one of my identifiers, right? Or if we agree on how we're going to cross-identify folks. That model, I think, will continue for at least several years, and for partners that may want to use it, probably even longer than that. In the sense that the reluctance or the concern about doing a completely deterministic matching using just demographic information is still very complex from a healthcare perspective. I can tell you that initially in some of the Da Vinci use case, and I'll use payer to payer as an example, because that is one in which it brought the concept of how do we match between payers to a head, right? And this was about 2 years ago. The initial approach was a deterministic match. Give me first name, last name, zip code, date of birth, a couple of other identifiers, and we'll agree that, Patrick Murta is Patrick Murta. That didn't fly, right? We were uncomfortable with that. So the deterministic match in today's world includes all of those, plus your the member identifier. So that we're going to say, here's Patrick Murta, and by the way, for the older or the previous payer, here's your identification number, your member number, your patient number, whatever, so that we prove that we have an identifier that you agree with, or that was used previously for a payer. I think those models will continue for several years. I do think that the distributed identity management that is being used in other industries to success will eventually find its way into healthcare. But I think it's going to be take a bit of time for that to happen. So if I'm guessing, I'm thinking 2 to 5 years before we go much beyond what's happening from a collaborative patient matching perspective.
We had Ryan Howells come in and talk about the work that he's been involved in with Karen. And, as you've heard Ryan say many more times than I have, we all have a patient identifier. It's called a social security number. The problems that are involved in using that for that particular purpose are long and tortured. The political process is tortured about this. We also have, in our hands or in our shirt pockets, the kind of technology that can authenticate us and identify us. But as you point out, we have a long way to go to having that kind of portability. And we have HIEs with large data sets, and we have plans, as you pointed out, who need to share data with an enrollee or member's next plan that can't take advantage of these new technologies right away. So thank you for that. That was a great answer. Janice, maybe I can ask for you to give us the questions that we have coming, and we'll allow Patrick an opportunity to answer them.
Sounds great. I've collated a bunch of questions together into groups. So there were a couple of questions that were asking different aspects of what fire stuff is actually available now in use by different people, and how do you see that evolving over the next 1, 5, 10 years? So if you have some other examples of things that you think are worth calling out, and sort of just a percentage of how much of your business is happening, or things in general happening via API, via Fire, and other ways,
Gotcha.
that would be great.
Yeah, that's probably, I think maybe answering the second part of it first is really real important. And transparently, a very, very, very small majority of our overall transaction volume is Fire-based at this point, right? Because, you know, as all organizations do, many of our transactions run over, you know, for our X12 administrative side of the world, that is the majority of transactions that we do on a daily basis. There are, you know, the ADT message, and those are super high volume as well. We also have, you know, for example, we typically rate things as gold, silver, and bronze, meaning gold, you know, Fire-based, you know, standards-based. That's a fairly small percentage. We do have a lot of contemporary or APIs that are maybe not standards-based that we measure transaction volume in the millions. From a Fire perspective, we probably, we have, you know, a couple of things. You have notifications, we've got the medication, we've got medication profiles. I'm going to say that, and also with the patient access API and the provider directory, we measure our volume from a Fire perspective, probably in the millions per month, but that's still small compared to our overall volume, which is, you know, millions per day. So again, it's a fairly small volume in today's world, but we have a Fire first mentality, meaning that can we solve the problem using Fire? If so, let's go for that. If not, do we need an intermediary solution until we can get Fire there? So again, it's relative, it's very modest at this point. It is growing, and I suspect it will take. I think the second part of the question, how long? Again, I like to give the 2 to 5 to 7 year time frame because it gives me a little bit of a hedge there. But I think it's going faster than many of us expected, but not nearly as fast as many of us would like. But I think, you know, we still have a fairly long runway of, you know, 2 to 5 to 7 years before we hit critical mass. There may have been another part of that question, Janice, that I missed.
I think that's a good starting point for folks. So I'm going to combine together a bunch of questions about sort of the role of regulation.
Yep.
So can you elaborate on care coordination activities that you see being driven by federal regulations as well as industry initiatives? Do you see what role do you see Fire playing in meeting various No Surprises Act requirements, both price transparency and otherwise? And do you see regulation continuing to drive us into a more patient-centric view of the world?
Yes, there was a lot there. So as I don't know why I keep answering these questions in reverse order, but so
no worries.
I see it as this. I do see that it's obvious that regulation is moving in a world of, you know, patient-centric or patient-mediated exchange of data in healthcare. I think that's hopefully obvious, and that's not just Patrick thinking that. I think the patient access API 9115 rule was a first step in a series of steps. I don't think it stops there. I think it's going to continue on, right? But I also think there are organic or market forces that are doing the same thing. So I think the CMS, the regulations for the most part, CMS or ONC, whatever your flavor is, are moving towards that. But I also see, in one of my slides, called it out at the bottom, I didn't mention it, but is that there are market forces that are pushing the same thing forward. And this is where the concept of organizational differentiation comes into being, right? Because the rules are going to continue to push this forward. So you can wait for the rule to push you to do this, which, you know, okay. Or if you recognize that this is the future, not just because CMS says it is, but because this is the way the organism or the organizations are going, patient mediation, exchange of data, real time, right data, right outcome, right workflow, right time. Those market forces are driving it or propelling it forward is equally as importantly. So if I look at my portfolio of use cases, I talked about maybe 2 that were CMS driven in today's discussion, and probably hit at least 6 or 7 others that were not driven by CMS regulation or ONC regulation, but solved a specific business or organization or clinical opportunity that we had. So see, the rules are going to continue to come, but you've got to think about it more than that. You've got to think, what can you bring to your organization by moving this technology forward as well?
I would add just briefly to that, and what we see from the consortium perspective is that once you start sharing data at scale, or sort of think right to left about what will this provide us as an organization, beyond compliance with regulations, beyond quality measures and the like, you can start to redraw the boundaries around what constitutes a healthcare provider and what constitutes a healthcare payer. Much more will be in the gray areas where they collaborate together and decide not to each invest in technologies that they can share, for example, or care coordination or social determinants of health are areas where health plan and healthcare provider collaboration are essential. We can't all go off with our own data and start running our own analyses without help and without a community of people who will help us. So I think that's another force around bringing organizations together to solve problems collaboratively. Now that we've gotten over the data hurdle, now we can start talking about, well, maybe my organization doesn't have to do this on its own. Maybe we can work with our health plan partners or with our provider partners and solve this problem together.
Yep.
Janice, go ahead.
Great. Any specific comments on either any components of the No Surprises Act, or, as Denny mentioned it, to care coordination specifically?
Well, so I think, so from a care coordination perspective, absolutely. And again, going back to the CMS regulation for payer to payer, that is an aspect of care coordination that the FHIR is going to bring. A lot of FHIR basically brings a solution for that. But again, going above and beyond the regulation, care coordination with integrated care plans that we talked about a few minutes ago. I think there is a really big opportunity there for that type of thing, between virtual care, in-home, PCP care. That type of thing will all be enabled via FHIR. And I can tell you, the infrastructure, we do FHIR-enabled transactions for virtual care now. The in-home that we've talked about earlier is FHIR-enabled. So I think care coordination, not only from a CMS perspective, but from a care delivery perspective, is organically pushing forward as well.
Sounds good. Denny, while I ask Patrick the next question, do you want to put the poll up for people?
Yeah, let's do that. Let's start a poll while we got people on the line. This is only a 2-question poll, so please, by all means, give us your opinions, and we'll end the poll in approximately 30 to 45 seconds.
All right, so while people are answering that, Patrick, we had several questions about different types of care, and some specifically about behavioral health and whether people are looking at that specifically. Also, we talked a bit about home health, other post-acute areas, but do you see the need to look at these areas as separate areas that need focus, or do you think that the clinical data that's encompassed in USCDI and US Core enables those cases without necessarily a ton of direct focus on them?
No, you hit a sensitive issue there, Janice, is that I think behavioral health is being missed. I think historically behavioral health has been behind the curve as it relates to integration, interoperability, and I see it's not on par or equity with the way that other domains of healthcare or the other specialties are going. So I think focus on behavioral health, like we've done on SDOH and others, is going to be key. As a matter of fact, I would love to see a behavioral health HL7 accelerator, to be transparent with you, because it just is not being given the appropriate focus and the appropriate attention that a subject that is becoming, let's be honest, in a pandemic times with things happening around us, is that the ability to serve folks, with mental health issues is going to require a level of integration, interoperability that is not currently being addressed.
Sounds good. So what do you say to folks who are currently using X12 EDI and have been doing it that way for a long time and don't fully understand why they might want to change some of their processes to move to FHIR instead? Great question. And well, if you're using X12 and EDI, you're going to be using X12 and EDI for the foreseeable future, because for the most part, it's required by OCR as it relates to the HIPAA implementation, right? And I'm an X12 guy. I grew up on X12. I implemented our entire X12 infrastructure in my organization and helped create clearinghouses. X12 solves purposes that it was designed to solve. It does not solve in workflow integration. That is not what the technology is built for. If you want to do, claims adjudication, financial transactions between PMSs and payers and stuff like that, X12 is going to be there for a while. What I would ask you to do is consider use cases that you may have subconsciously suppressed or not addressed because you did not have the technology to deal with it, right? X12 is not a good technology to serve up an app in a workflow and ask a questionnaire, whatever the case may be. FHIR and SMART are much superior technologies. I see these as complementary to each other for the foreseeable future. In 25 years or 30 years, will FHIR maybe do the stuff that X12 does? Maybe, don't know. But for the foreseeable future, these are complementary technologies which can benefit each other. All right, sounds good. Last question. There's 4 minutes left. You can go for all of those 4 minutes if you'd like. Do it. What do you see as the future of FHIR? What are the handful of things that you think are most important, that you'd most like to see FHIR evolve into covering or handling or doing or seeing people adopt in FHIR? No, that's a good question. And the most important thing is, I want to see more implementations in real life, in the real world, right? We've been talking about FHIR for 10 years at this point. It's not a new technology. It's been around for 10 years. We've got some good use cases in production. We've developed use cases and implementation guides as an industry. We need to bring that technology to bear to remove some of the abrasions that we have in healthcare. That's the bottom line, is we need to continue to, and I'm not saying people are not implementing, they are, and the appetite is growing, especially on the provider side. I see that the desire to do this becoming broader and broader. So I think implementation of existing and new evolving use cases is going to be critical. And I forgot the second part, Janice, sorry. That's okay. If there were just a couple of areas that you don't think are getting adequate attention that you think should get attention in the future. I would like to see, you already hit on one of them, behavioral health. I don't know what it's lagging behind. We got to fix that. And I also think the integrated care plan is a big one as well. Is folks are staying in their home, the in-home providers, telemedicine, virtual visits are becoming more prominent. The ability for sharing of information using these standards between clinicians, the patient, caregivers, whatever, to ensure that folks are getting the appropriate level of engagement and care, whether it's clinical, whether it's caregiver. I think there's a huge opportunity there. I think we'll see a lot of advancement in third-party development APIs using these standards as well. But that's where I see, and there's also provider to payer and payer to provider is going to go gangbusters on FHIR. I'm convinced of that, as it relates to a lot of the things that we need to do within workflow integration. So that's a given for me. That is going to happen. I think bringing others on the periphery, the caregivers, others into the fold with apps is going to require a little bit more incubation. Yeah, payer and provider interoperability and interactions, definitely a big focus of MEGC. So glad to hear you mention that. If it's okay, I might forward some of these additional questions to you. If you have a chance to answer some of them, that would be appreciated. Absolutely. And with that, I'm going to hand back to Denny for a final word. Thank you, Janice. We have just a minute left.
Chris Fugere, you've raised your hand. I'm going to give you a chance to ask a question. I hope it's brief, given the time we have. Why don't you tell us what your question is?
Thanks, Denny. My name's Chris. I'm the senior solution architect at Boston, Massachusetts Blue Cross Blue Shield, and I had a question, two questions actually that weren't addressed. One was the workflow with the questionnaire that popped up. Is that an actual live workflow that you have out there with an EHR currently?
It is, yes.
Okay. Okay. Second one was, I completely agree with you on the use cases that are out there. My problem is trying to drive adoption with FHIR and getting people to buy in.
Mhm.
So
Chris, so
enlighten me.
yeah, no, brother, I'm with you, man. And so to answer your first question, that is actually a DTR app. So if you look at the DaVinci spec, DTR app is that thing that I showed on the screen that's in the EHR. It's in one EHR now, it'll be in the second EHR and the third EHR next year. Your second question is adoption, and I totally agree with you, is that the message has been evangelized. The uptake is getting better, right? Especially from the provider community and the other EHR and other EHRs and things like that. It's improving. It's not as good as we would like. So I think as far as we've got to engage providers better. The experience that we have seen is that when we can get to a provider and show them the value to their workflow and to their patients on this type of integration, then the appetite gets better. And we've had some really, really good successes with that. I don't have a silver bullet to say, click here, Chris, and all your adoption woes will be solved. But the engagement directly and explaining the value, both from a community perspective through some of these HL7 accelerators, and also your organization's relationships with your regional providers will help you if you can get in front of these folks through your representatives.
Well, thank you for the question, Chris. Patrick, thank you for your time today. I want to thank Patrick, integration master, health plan thought leader, Humana architect extraordinaire, for spending time with us today. We see each other across the transom at various accelerators and across the chasm that represents the Zoom meeting. And it's a great pleasure to have you talking with us directly today. I want to thank you. I want to thank all of those who joined you, especially those of you who are members of MHDC. Those of you who are not, please contact us and find out what more you can get by joining us. And with that, I will again thank you, Patrick, and say that we're adjourned. Thank you, everybody.
Thank you.
Thank you.